to the next speaker, Dr. PRATEEK TEOTIA, who's again a senior consultant cornea, cataract and refractive surgery from Center for Sight, Delhi, and he is going to be telling us about iatrogenic ectasia, early diagnostic indications and management options. On to you, Doctor.
So good evening, everyone. The topic of my today's presentation is iatrogenic ectasia, early diagnostic indicators and management options. So it's iatrogenic corneal ectasia is a rare but most dreaded complication that can occur after uneventful corneal surgery. First, it was described by Professor Theosella, and it can lead to vision impairment and morbidity, causing frustration and dissatisfaction for both patients and refractive surgeons. It's more common after LASIK but can occur after post-SMILE, RK and PRK. And it is postulated to occur as a result of insufficient corneal thickness, exacerbation of pre-existing subclinical or clinical keratoconus by further weakening of the corneal structure, and or the development of genetically predetermined ectasia occurring years after refractive surgery. So the risk factors are preoperative ectatic disease, which may occur despite normal topography, correction of high myopia, doing treatment in younger age group, in cases of thin cornea, if you leave low residual stromal bed thickness, if there is excessive ablation or thick flap creation during performing LASIK, if patient undergoes multiple enhancements, if there is small optic zone or there is abnormal corneal rigidity, if patient has history of eye rubbing or trauma after surgery. Recently, it has been found that if there are increased level of inflammatory mediators such as interleukin C, TNF alpha, and MMP9 in tears, it can also lead to post-LASIK ectasia, and there could be undetermined factors which could lead to post-LASIK ectasia. This has been discussed that risk score systems have been devised to predict the outcome of post-LASIK ectasia. PTA which is calculated as flap thickness plus ablation depth upon central corneal thickness has to be less than 40% because the anterior stroma is more compact and it has more tensile strength than the posterior stroma. So we would like to preserve the stiff cornea in cases of refractive correction. Despite all these scoring systems, there is no one can guarantee that post-LASIK ectasia will not happen. Despite taking all precautions, we see cases of post-refractive ectasia. So with the advent of advanced tomographers such as Pentacam, we can detect early cases of formifrostic keratoconus, and Berlin ambrosia display and corneal thickness distribution data can eliminate the inherent accuracies of curvature-based measurements. So doing complete corneal tomography and tomography helps in comprehensive evaluation of both the anterior and posterior surfaces, as well as full pachymetry mapping of the cornea is important in establishing the diagnosis of corneal ectatic disease following its course. With the advent of Corvis ST, we can add this in our armamentarium to detect the cases which have low biomechanical strength. Higher order aberration of the anterior and posterior corneal surfaces are altered in keratoconus and have been evaluated as a means of detecting both clinical and subclinical disease. Changes in wavefront analysis such as increasing of higher order aberrations, particularly vertical coma, other aberrations such as spherical aberration and trefoil aberration may also be present in these patients. OCT, we can get the epithelium map and which show that there is central thinning over the area of the cone and we can get a classic donut shaped appearance in cases of pachymetry map of epithelium, and this also can help us in detecting early cases of ectasia. It is important to differentiate a decentered ablation from progressive ectasia because in ectasia immediate results are good. There is no early inferior stiffening, but there is secondary decrease of visual acuity, and it shows progression, and laser treatment may worsen the situation, though it is just opposite in cases of decentered ablation. So treatment options for ectasia after laser vision corrections, patient education is most important because these patients are demanding patients. They have chosen refractive surgery for removal of glasses or for reducing dependence on glasses. But in early cases, we may need to depend on glasses or contact lenses. CXL may help in cessation of progression, and for visual rehabilitation, we can go with contact lenses, Intex, PTK combined with PRK and collagen. In advanced cases, we may have to go with DALK or penetrating keratoplasty. For final visual rehabilitation, we can combine various treatment strategies, such as first, we can stabilize the cone with the help of C3R. It will prevent progression of keratoconus. We can flatten the cone and reduce the refractive error with the help of ICRS. And later we can correct the refractive error and emmetropia with ICLs as shown by Dr. Chaudhary. And in advanced cases, we have to go with DALK and PK. So I'm skipping a few slides that in post-LASIK ectasia, the response is to CXL is not as good as in cases of primary keratoconus patient. This is because of biomechanical difference caused by the LASIK flap, possible differences in the riboflavin diffusion rate in post-LASIK corneas, especially at the flap interface. Increasing pathophysiological differences between keratoconus and ectasia may all contribute to the different response, and response is not as robust as keratoconus patients. ICRS is a modality which is used as for the visual rehabilitation. It acts as a passive spacing agent which flatten the cornea. So there are various rings such as Intex, Ferrara, Kera ring, or BioRing. These rings they are made up of PMA. So with the help of femtosecond laser, we create the channels, and with a special spatula, we open these channels. It is better to create the channels with the help of femtosecond laser because it is more precise compared to the mechanical creation of these channels. So once the channels are open, then we can insert the rings. Either we can insert one ring or two rings depending upon the location of the cone, whether it is central or peripheral. So basically these ICRS work by shortening the arc length of the cornea, and they flatten on and in between the segment tips and stiffen on the segment body. Smaller the diameter, the greater is the correction, and the greater the thickness, the greater is the correction. So this is the Schimflach image showing the presentation of Intex in the corneal stroma. So whether to do sequential CXL and ICRS or whether to do simultaneous. So CXL, if we do first and then it is followed by CRS, so progression can be arrested by CXL and it improves the corneal rigidity. Corneal shape is normalized by ICRS. Mechanical flattening effect is less than predicted if we implant simple ICRS, and there is delay in visual recovery. Also, the creation of channels by femtosecond laser is difficult, so we need to increase the energy settings of the femtosecond laser to create the channels for ICRS if we plan it post CXL. I prefer simultaneous combination of CXL and ICRS because maximal mechanical flattening effect with intracorneal ring segment and further progression arrested by CXL. Also, they have a additive effect when you do them simultaneously. There is a synergistic effect because of the increased biomechanical rigidity of CXL. It alters pattern and distribution of collagen changes with ICRS, and areas of increased riboflavin concentration between the intercorneal ring segments with increased collagen cross-linkage. So this was a case which patient had this left eye at presentation with mean K 41.6 and the BCVA was 6.9. So at this stage, left eye C3R was done, and despite C3R, patient went for progression during pregnancy. And this was the right eye at presentation with mean K 40.9 with BCV of 6.9. This patient went for C3R plus Intex, and during pregnancy, this eye was more stable. So from this case, we learned that ICR is a very useful technique modality in cases of post-LASIK ectasia, but we need to prevent this condition. So role of extras has come. The combination of PRK or LASIK or SMILE with accelerated cross-linking has been practiced to prevent ectasia in moderate to high risk cases. We normally prefer SMILE extra, but nowadays PRK extra is also gaining prominence. Whether it is for everyone, no, the present indications are thin cornea, high myopia if you are treating more than 6 diopter, if there is a family history of keratoconus, if there is topographic asymmetry, and if there is difference in astigmatism between two eyes greater than 0.75 diopter in young patient, and in hyperopes, you can do it to prevent regression. So careful screening is necessary before planning refractive surgery. PRK SMILE might be presumed to have reduced risk due to better corneal biomechanics, new modalities of combining CXL with laser vision correction, and Intex plus CXL may still give a good uncorrected visual acuity after ectasia. Thank you.
Thank you very much, Doctor, for such a detailed talk on iatrogenic ectasia. I have a question to you, Vanti. If you have a patient who has an iatrogenic ectasia in one eye, would you actually ever consider doing a prophylactic cross-linking for the other eye?
We will keep him under observation, ma'am, if the other eye is normal.
No, I want, okay, yeah, you observe. Yeah, I wanted Dr. Vaniti, unmute yourself. The question was to you. Thank you, Dr. Prateek.
Hi, Dr. Chitra. Yes, I think I agree with Dr. Prateek. I would also observe before I jump into doing a collagen cross-linking for such patients.
Yeah. Just another question which might actually make Dr. Sanjay happy. But the thing is, yesterday only I saw one patient of SMILE with ectasia with a -2 diopter, unmarried, no allergies, who had got it done some 7 years back. If I look at the topography, I would have still suggested a SMILE procedure for her had I seen it now. I mean, but she had gone in for ectasia. So what are your reports all over, like being a major premier institute, they would be analyzing results. Do you feel that anyway ectasia has become very rare because our topographic understanding and the clues which you pick up is so definitive? But do you feel that SMILE is nearly on par with the other procedures?
I think when you are screening for refractive surgery, the screening parameters are pretty much similar, whether be it LASIK, whether be it SMILE, or whether you're looking at PRK. So it's not perhaps about the quantum of refractive error which needs to be corrected, but the emphasis now is on the corneal biomechanics for a particular cornea, and the way the healing process after the refractive procedure is going to affect the biomechanics in the time to come. So that is the million dollar question as to how is this particular cornea going to react to a particular type of procedure, be it a flap or a non-flap based procedure here. So perhaps the current imaging modalities is still lacking, or there is a small lacunae in which we are not able to clinch on that particular aspect, which is really going to be a biomarker to predict if this cornea is going to go into an ectasia. Till then, we perhaps have whatever we have in our hands, and we are looking at the suspicious topographies. So sometimes perhaps maybe we are missing those subtle markers. And we know today that perhaps we have more subtle markers than what we had 7 years ago. Yes. So that's my take on it.
Dr. Radhika, your question?
Yeah, so basically on the subject of post-LASIK ectasia, so though there are so many parameters which will tell us whether keratoconus is progressing or not, there are very few which will tell us whether the post-LASIK ectasia is progressing or not, because the bad screening becomes completely invalid in a post-LASIK ectasia. We're altering the anterior curvature, we're altering the posterior curvature, the thickness is changed, the relational thickness from center to periphery is changed. So the point that I'm trying to make or ask is that there are very few indicators to know whether the ectasia, once it's unmasked, is stable or is it progressing. Given that context, I would, and also knowing that cross-linking has got very less effect in a post-LASIK ectasia compared to keratoconus, I would err on the side of early cross-linking without waiting for progression. However, years back, Dr. Prema Padmanabhan has published a paper which talks about stability of ectasia and gradation of post-LASIK ectasia. So that if grade 1 is going to grade 2, then we know that it's progressing, including the fallacies of BAD and all the systems in finding it out. Dr. Sudhir, if I remember, was a co-author of that paper. So Sudhir, can you shed us some light on how to assess progression of post-LASIK ectasia and whether you would actually wait to see if the grades progress or whether you would do the cross-linking immediately like I would?
Thanks, Radhika. I think this was a paper where we looked at ways in which how to grade the post-LASIK ectasia using based on the cases which we had seen, almost like 30 cases. And we looked at the elevation parameters, the thinnest point, thinnest pachy, the shift in the thinnest pachy, and also the these are few things which were early markers to identify whether there is post-LASIK ectasia. And again, the cylindrical power, which is increasing. So these were few parameters which we identified and graded them based on the scoring which we developed. And that will tell us whether we are in the grade 1, grade 2, grade 3 or 4. And we can see whether it is, we can follow them if it is in the grade 1. If it is, patient is shifting from grade 1 to 2, then we need to go ahead and go ahead with collagen cross-linking. One more point which I need to add up is whenever we are doing a post-LASIK ectasia collagen cross-linking, the debriding of epithelium, we have to be very careful. You have to know where the hinge of the flap is and then do the debriding. So that is one more thing which I need to look at. Yeah.
Thank
Thanks
you.
for
Yes. Thank you. That was all very wonderful.